Hello, my name is Kevin McGrath. I'm an Associate Professor of Medicine at the University of Pittsburgh Medical Center. Today, I'm happy to discuss our manuscript to be published in Gastrointestinal Endoscopy entitled Endotherapy for Superficial Adenocarcinoma of the Esophagus, an American Experience. As you're probably aware, adenocarcinoma of the esophagus is the fastest rising cancer in the United States. Its incidence has increased six-fold over the last 3 decades. In recent years, there's been a growing body of literature from European centers supporting excellent safety and patient outcomes for primary endotherapy for early Barrett's-related neoplasia. Endoscopic mucosal resection for low-risk T1A lesions has been shown to be curative, and ablation of the remaining Barrett's epithelium decreases the risk of metachronous neoplasia. The German and Dutch experiences have brought endotherapy, notably endoscopic mucosal resection, to the forefront of treatment regarding low-risk mucosal-based esophageal adenocarcinoma. However, based on comparative patient numbers, the experience has lagged in the United States. Our Barrett Center has seen an increase in the rate of referrals for management of high-grade dysplasia and superficial cancer that parallels the increasing rate of adenocarcinoma of the esophagus. We therefore sought to review our experience of primary endotherapy for management of esophageal adenocarcinoma. We performed a retrospective review over a 6-year period. Our inclusion criteria were patients with a low-risk T1A adenocarcinoma of the esophagus managed by primary endotherapy and a minimum 3-month follow-up. A low-risk T1A lesion was defined by the presence of well to moderate tumor differentiation and lack of submucosal and angiolymphatic invasion. Our primary outcome measurement was death related to esophageal cancer, and secondary outcome measurements were remission rates for cancer, dysplasia, and intestinal metaplasia. Our cohort consisted of 54 patients, all of whom underwent endoscopic mucosal resection of a low-risk T1A lesion. The mean size of the resected adenocarcinoma was 7 millimeters. The mean Barrett length was 4.5 centimeters, and 20% of the group had multifocal adenocarcinoma. Roughly 80% of the patients have undergone endoscopic ablation of remnant Barrett's. The mean length of follow-up of our study was only 23 months. However, this is due to the increasing rate of referrals for endoscopic management of these patients in our center. We acknowledge that our short follow-up is somewhat immature compared to some other published series. The complete remission for cancer was 96%, which is similar to other published experiences. Our remission rate for dysplasia was 87%, and for intestinal metaplasia, 59%. Many patients in the cohort continue to undergo endoscopic ablation of remnant Barrett's, and we expect these percentages to increase with ongoing therapy. The overall survival of our cohort was 89%. However, no patient died of esophageal cancer, nor has any patient developed a lymph node metastasis. Our experience, although smaller with shorter follow-up, parallels that of the larger European series. In the largest study to date, by Dr. L's group, none of 231 patients with low-risk T1A lesions died of esophageal cancer or developed a lymph node metastasis. The mean length of follow-up for that study was 5 years. The overall survival was no different than the average German population when matched for age and gender. The obvious concern regarding endoscopic management of these superficial cancers is the metastatic risk. As I mentioned, none of the patients in the large German experience developed a lymph node metastasis. If we look at the 8 largest single-center surgical series for superficial esophageal cancer, 8 of 317 pooled patients, or 2.5%, had a lymph node metastasis at the time of esophagectomy. In the largest series of 75 patients, only 1 patient had a lymph node metastasis. Specifically, this patient had a 2.2 centimeter lesion with poor differentiation and angiolymphatic invasion. Obviously, this would not be a lesion considered appropriate for primary endotherapy. Of the 7 other patients, there were no further pathologic characteristics reported, so we don't know whether they also were high-risk lesions. Existing literature, now to incorporate our experience, supports endotherapy for management of low-risk T1A esophageal adenocarcinoma. The complication rate of endotherapy is far lower than the 20 to 40% surgical morbidity rate of esophagectomy. The true lymph node metastatic rate of a low-risk T1A lesion is likely less than the surgical mortality of esophagectomy at many experienced centers. We believe that endoscopic mucosal resection, followed by ablation of any remnant Barrett's, should be considered the treatment of choice for low-risk T1A esophageal adenocarcinoma. We also believe that as awareness increases, the American experience will continue to grow and offer this safer yet equally efficacious treatment which preserves the esophagus. A lingering question, at least in our mind, regards surveillance when dealing with these low-risk lesions. We believe that diligent endoscopic follow-up is very important. However, we question the utility of EUS, CT, and/or PET surveillance. We believe this is an area deserving of further research. Thank you.